Hello friends. Today we are going to discuss about the drug-induced liver injury, which was also the question which was asked in DRNB critical care exam in 2024. Drug-induced liver injury is defined as liver injury caused by various drugs, herbs, and other xenobiotics leading to the abnormalities in the liver function. Clinical chemistry criteria for DILI is defined as elevation of alanine aminotransferase or aspartate aminotransferase more than 5 times of upper limit of normal without symptom, or rise in alkaline phosphatase more than 2 times of upper normal limit, rise in bilirubin of more than 2 times of upper level of normal with any rise of AST and ALT, and rise of AST or ALT less than 5 times of upper level of normal without symptom. If liver injury recurs within 6 months, it is called as acute liver injury, and if it is persist for more than 6 months, it is said to be the chronic liver injury. ALA accounts for most cases of the DILI, and it is divided into hepatocellular, cholestatic, and mixed type based on the R ratio. The R ratio is calculated by dividing ALT by ALP using multiples of upper level of normal for both values. R ratios of more than 5 define hepatocellular, less than 2 cholestatic, and between 2 to 5 is the mixed pattern of enzymes. Now, diagnosis of drug-induced liver injury. About history. The most important factor for diagnosis of DILI is careful history taking, because DILI is diagnosis of exclusion. The history of drug administration and the onset and progression of liver biochemical and abnormalities must be accurate. The Roussel-Uclaf casualty assessment method. The Roussel-Uclaf casualty assessment method, that is UCAM, is a diagnostic tool that makes probabilistic decision using scorecard, and it is divided into 7 categories. Total score ranges from less than 0 to 40, and the final score is interpreted as follows. That is highly probable more if score is more than 8, probable if score is between 6 to 8, possible if score is between 3 to 5, unlikely if score is between 1 to 2, and if it is less than 0, then exclude. So this is the spectrum of drug-induced liver injury. The spectrum of drug-induced liver injury is variable and broad from the asymptomatic to the liver failure. Drug can damage not only hepatocyte but also cholangiocytes, stellate cell, sinusoidal endothelial cell, and then can cause acute hepatitis, chronic hepatitis, granulomatous hepatitis, neoplasia, cholestasis, cholangitis, vascular disease, and fibrosis. Now, according to ACG guideline, liver biopsy should be considered if autoimmune hepatitis remain competing etiology and if immunosuppressive therapy is contemplated. Moreover, the liver biopsy may be considered if liver biochemistry continue to increase or liver function deteriorates despite the interruption of suspected drug. If the peak ALT level has not dropped by more than 50% at 30 to 60 days after onset in case of hepatocellular DILI, and if peak ALT level has not dropped by more than 50% at 180 days in case of cholestatic DILI, despite stopping suspected offending agent, in case of DILI where continued use or re-exposure to implicated agent is expected, and if liver biochemistry abnormality persists beyond 180 days in the evolution of presence of chronic liver disease and chronic DILI. Then biomarkers. Recently, there has been growing interest in the finding biomarkers that predict the occurrence of DILI, accurately diagnose it, and predict the poor prognosis. Biomarker candidates such as glutamate dehydrogenase, high mobility group box 1, keratin 18 have been found, and the DILI studies using microribonucleic acid, high throughput proteomics, genomics, and the metabolomics have been attempted. Mechanism of drug-induced liver injury. Traditionally, DILI has been reported to be caused by intrinsic and the idiosyncratic reaction, and sometimes both may occur together. Intrinsic liver injury is dose dependent and the predictive. On the other hand, idiosyncratic liver injury is divided into immunoallergic and metabolic idiosyncratic reaction regardless of dose, and it is unpredictable. High daily doses, that is more than 50 mg per day, is associated with serious hepatic event such as liver failure, liver transplantation, and death. But there was no association with the lower daily doses, that is less than 10 mg. In other words, hepatocyte injury mechanism is divided into three stages. That is hepatocyte injury, mitochondrial permeability transition belonging to downstream, and hepatocyte death. So this is the mechanism of drug-induced liver injury. The hepatocyte injury mechanism is divided into three stages. First stage, that is initial hepatocellular injury. The injury is excreted through direct cell stress, direct mitochondrial inhibition, and specific immune reaction. Second stage, the mitochondrial permeability. The initially lead to the a mitochondrial permeability transition. Direct cell stress causes mitochondrial permeability transition via intrinsic pathway. And then final stage, that is hepatocyte death. The mitochondrial permeability transition leads to necrosis and apoptosis, depending on the availability of the ATP, which is not uniformly progressive from initial hepatocyte injury to the third stage, and damaged hepatocyte can be recovered depending on their defense and regeneration ability. Various environmental factors and genetic factors are involved in each stage, and the degree of individual liver injury is different. The initial hepatocyte injury is caused by a drug that is not uniformly progressed to the third stage, but the injured hepatocyte may be recovered with the defense and regeneration ability of the patient. In addition, various environmental genetic factors are involved in each stage, and the degree of individual liver injury is different. So, individual differences in the drug-induced liver injury. The risk factor for the DILI can be divided into genetic and environmental factors. Genetic factor includes the mutation in the cytochrome P450 enzyme, the expression of transport protein and the nuclear receptor, and changes in the level of immune component. Environmental factors include old age, female gender, drug combination, previous drug adverse reaction, nutritional status, pregnancy, alcohol consumption, inflammation, and existing disease. Changes in the gut microbiota affect the drug metabolism and immune system, and it is interesting that it is one of the risk factor of the disease. Now, the risk factor for the drug-induced enzyme is drug-induced liver injury is, as I have described before, the genetic factor and environmental factor. So we'll quickly summarize this. Genetic factor includes the mutation in this enzymes plus nuclear receptor, maybe immunological cause, cytokine causes, mitochondrial mutation. Environmental factor includes age, sex, race, drug interaction, alcohol, inflammation, underlying disease, pre-existing liver disease as found in the HIV, diabetes, pregnancy, nutrition, and previous history. So, drug-induced liver injury in patient with pre-existing liver disease. There is much debate over whether DILI occurs most frequently in patient with pre-existing liver disease than in the normal patient. There are several exceptions, but there are not more frequent. However, it is known that DILI is more critical and has high mortality rate in patient with pre-existing liver disease. DILI is usually reversible and considered benign. However, it sometimes progresses to hepatic failure, requiring liver transplantation and causing death. According to the Hyman-Zimmerman-Hayes law, the hepatocellular type of DILI is known to have mortality rate of over 10% if accompanied with jaundice. Index predicting ALF in DILI has been recently proposed by Robles Diaz et al., which integrates Hayes law with new R ratio, which demonstrates sensitivity of 90% and specificity of 63%. NR is calculated as highest AST or ALT or ULN, and AST is substituted for ALT if AST yields the greater R ratio. Recently, the drug-induced liver toxicity ALF score was developed to predict progression of a liver failure in DILI. Scoring is based on platelet count and the total bilirubin. Although specificity was slightly lower, sensitivity was higher than those of Hill's law criteria. The risk of liver failure becomes higher as platelet count decreases and TB and total bilirubin increases. Now about treatment, stopping suspected drug is the key to treatment. Other treatment involves administration of N-acetylcysteine and steroid, and liver transplantation are considered when hepatic failure occurs. Now about stopping the suspected drug. Follow-ups are necessarily after stopping not only the suspected drug, but about herbal medicine, plant preparation, and health food. Depending on whether when drug is discontinued, severity of liver injury can vary. Therefore, drugs should be stopped as early as possible. And since such a liver injuries are reversible to normal state, it is necessary to repeat liver function test after stopping the medication. In some cases, even if a drug is discontinued, it may not be immediately improve the liver condition and the liver injury may continue. Therefore, careful follow-up must be performed. It is very difficult to assess if drug should be continued if there is rise in hepatic enzyme in liver function test during the course of treatment. So further, if suspected causative drug is important for control of underlying disease, the balance between risk of progression of underlying disease after drug withdrawal and risk of exacerbation of liver injury due to continued administration of potentially related drug should be considered. According to the stop rule of new drug developed by US Food and Drug Administration, the guidelines are based on AST, ALT, and total bilirubin, and the medication being administered should be immediately stopped when any of the following results are obtained. That is when AST or ALT more than 8 times of upper level of normal, AST or ALT remains more than 5 times of upper level of normal over 2 weeks, AST or ALT of more than 3 times of upper level of normal, or total bilirubin of more than 2 times of upper level of normal, or INR of more than 1.5. AST or ALT of more than 3 times of upper level of normal with symptoms, that is fatigue, nausea, vomiting, right upper quadrant pain, fever and rash or eosinophil. Now about specific treatment, there is no specific therapy available. NAC, that is IV infusion of 50 to 150 mg per kg per day, may be administered for at least 3 days in patients with early and sub-ALF, and it is not recommended for children with severe disease as it can lead to ALF. Several studies have shown that steroid can prove effective. However, there may have been debate on the efficacy of corticosteroid in the treatment patient with the DILI. In case of immunoallergic and the autoimmune hepatitis like DILI, the administration of glucocorticoid may be considered. Now, re-administration of suspected drug. Although there is controversy regarding unconditional re-administration of all suspected drug that cause DILI, care should be taken care because re-administration of immunoallergic reacting drug may cause more severe liver damage than before. Now about liver transplantation criteria. If it is related to the acetaminophen ALF, then pH less than 7.3 and lactate more than 3, and grade 3 and 4 hepatic encephalopathy, INR more than 6.5 and create more than 3.4. If it is non-paracetamol related, then the single criteria includes INR of more than 6.5 and 3 of 5 criteria, that is age less than 10, more than 40, time from jaundice to coma less than more than 7 days, INR more than 3.5 days, bilirubin more than 17, and unfavorable etiology like drug-induced liver injury, Wilson's disease, and seronegative liver injury. Now, new treatment for DILI. Many studies have been actively pursued to develop therapeutic agents aimed at nuclear receptors in the DILI. Activation of constitutive androsten receptor and pregnant X receptor exacerbate hepatotoxicity by acetaminophen. The compound that inhibit CAR and PXL may be beneficial for treatment of hepatic damage induced by acetaminophen. Then farnesoid X receptor plays important role in the regulation of bile acid synthesis and metabolism. Farcinoid X receptor agonists such as obetanoic acid may have been considered as a promising target for the treatment of cholestatic disorder involving drug-induced cholestasis. Autophagy refers to the activity in which cell obtain energy by dissolving its protein or removing unnecessarily cell component when it becomes nutrient deficient. Recently, studies on autophagy have been actively conducted in various areas such as cancer, diabetes, infectious disease, and Crohn's disease. For DILI, new therapeutic approach is being attempted to reduce liver injury by controlling autophagy. Acetaminophen overdose results in hepatic necrosis caused by mitochondrial damage. The activation of autophagy degrades the damaged cytoplasmic protein, which allows cell to survive without cell necrosis. While liver injury is prevented by administration of rapamycin, 3-methyladenine, or chloroquine, they have been shown to decrease liver injury. Further, it is expected that several new treatments, including autophagy induction, will be developed and applied to the treatment of DILI in clinical practice. Thank you, guys.